All right, so we got a very interesting case today. So we have a mom, multiple kids, and so now she has some extra skin of her abdomen and some muscle separation, also known as diastasis. And so the goal today will be to remove a lot of the skin, remove a lot of this fat, do a muscle repair. You may be able to see from the side that she has a lot of protrusion from those pregnancies that she's had. But also we're gonna put this fat to use, and we're gonna do a petite BBL, nothing too crazy, just enough to, give her a little bit more pop in those yoga pants. We'll do my signature Lipo 400, where I lipo the upper back, the lower back, and the middle back, the sacrum area, the sides, the upper and lower abdomen, and the armpit area. Using tiny discrete incisions, we'll fill out the butt and just a little bit in the hips. I never have incisions underneath the butt. I never have any on the sides, never on the top. So everything's gonna be nice and hidden in a bikini. On top of that, she has a very, very boxy frame, and that's just her own natural genetics, nothing that she did or anything that she caused. And so we're gonna do rib remodeling with this tummy tuck and BBL to really, really bring that waist in. She's starting around 29 inches. If we can get her down to 22 to 23, I'll be very excited. One of the things she also has is she actually has very prominent anterior ribs. The left is a little bit more prominent than the right. I see that very often, especially as we are kids and we're formed. You often will see the lung, and then the heart forms on this side. And so as we are young children or young babies, that heart expands more on this side. And so it's not unusual to see that this rib has more anterior flare. So we're going to correct that anterior rib flare today as well, in addition to everything else we do. I'll show you when she breathes in. I just want to show you how prominent these ribs are. And this almost simulates doing a tummy tuck. And so if I remove this skin, tighten the muscle, she's still going to have quite a bit of prominence here along her ribs. So the rib remodeling, rib lux procedure will certainly help and address that today by bringing those in quite a bit. This is your spine, okay? And these are your ribs. So you do have all 12 sets of ribs. Mm-hmm. Your rib cage is very wide in general. Even though you're a very small, petite person, your rib cage is just very wide, wider than the average person. Mm-hmm. So the goal today will be from the back is to fracture rib number 12, 11, 10, 9, maybe even 8. But these are the ones that are really contributing to your very broad rib cage. 12, 11, those will be broken from the back. 10, 9, 8, 7, sometimes 6 will be broken in the front. And these are the ones that contribute to your barrel chest or that sticking out. So the goal is to get this a lot flatter, because if I just tighten the muscle, mm-hmm. you'll still have some protrusion up here because mm-hmm. your ribs stick out. So that's the plan. Mm-hmm. All right, so our patient today is 40 years old, and she's here for Vaser Lipo 400, a BBL, abdominoplasty with muscle repair, and rib lux anterior and posterior rib remodeling. She's currently prone under general anesthesia. The SCDs are on and confirmed to be working. Warmer for the bed is on above and below. Her hemoglobin today is 13.9, and her BMI is 22. Any anesthesia concerns?
No anesthesia concerns.
Okay. All right, so to start a tummy tuck BBL, I always start with the liposuction of the back. With my Lipo 400, I'm doing the entire upper back, the middle back, the lower back, the flanks and the waist, and then this pre-sacral triangle area. So by doing this area, it really helps give me a nice slope or takeoff to the butt. If I'm looking for more of a shelf look, I'm gonna empty this area out a lot more. If I'm looking for more of a slope look, I'm gonna leave more fat here. We always start with the back lipo contour. So liposuction always starts with tumescent fluid, and that's a clear fluid that we put inside the patient. It goes around the fat. It has epinephrine, which helps to decrease the size of the blood vessels, which also helps to decrease bleeding during the procedure. It also has pain medicine so that it makes the procedure more comfortable, whether you're doing it awake or asleep. And it also continues to give you pain control post-op while you're recovering for the first 8 to 12 hours. So that's tumescent, and it's just a clear fluid. So we always keep it warm so that it keeps you warm during your procedure. So I use Vaser with all of my liposuction cases. Vaser is an ultrasound guided energy device, and basically what it does is it helps to break up the fat from the surrounding tissue that holds it in place. By using this, we see a lot less contour irregularities. We are able to extract the fat in a faster, more controlled fashion, and we see a little bit better fat graft uptake. Transfer that to the hips, the buttocks, or wherever on the body I personally see a greater fat retention, so that's why I always use Vaser with my liposuction cases. When do we finish, or how do we know we're done with the liposuction? Well, it's really a very artistic thing that we do, and so no different than a car. Some people feel comfortable driving a car 70 miles an hour. Some people feel comfortable driving a race car 200 miles an hour. So it's all about the surgeon's comfort level with how much fat that they feel they can safely remove. So there's no exact number that tells us when we are done. It's more so a feel, and so often I do what's called a pinch thickness. And so once I know that I have the skin and the fat as thin as I want it, that's how I know when to stop. All right, so I have the ultrasound here. I'm looking at the buttocks before I put the fat in, and just to point out some anatomy that us as plastic surgeons are looking at. So one is, this is the muscle down below, and above the muscle is a layer of white tissue called the fascia, and then you have the deep layer of fat and the superficial layer of fat. When I'm treating cellulite with the ovule, for example, we're always in this superficial layer. When we're doing fat transfers, we're in this deep fat layer. The layer we're trying to avoid is the muscle here, because if we're in the muscle, that's a little bit dangerous, because that's where the large vessels are that can cause a fat embolus. And so we always try to stay above that muscle, and that's why I use ultrasound with my fat transfer. Some surgeons inject the muscle because you can get better projection when you do that, and you get a little bit greater fat retention. Still dangerous though, because we know that most cases where there's a fat embolus, it's because the surgeon injected the muscle, whether that was on purpose or accident. But people still do that to this day here in the United States and across the world. People are still willing to take that risk. To me, it's a little bit dangerous, so choose your surgeon carefully. Okay, so once again, you can see my cannula, the muscle is below, and I'm in the deep layer of fat, and as you see, there's a superficial layer even closer to the skin. So there's my cannula, and now you see the fat going in. You see the fat is coming in above the muscle, not in the muscle. So all those grayish lobules, that's the fat that I'm putting in, into the deep layer of fat. Whenever I do a fat transfer to the butt, the breast, or wherever, I always put a little bit more fat in, because I know that you don't keep it all. Your body breaks it down and then you excrete it at some point. So after about 3 months, whatever fat you have is usually pretty stable, usually 3 to 4 months. So we always go a little bit bigger, knowing that it's gonna come down. Now we're gonna start the posterior rib remodeling. So the most important concept to rib remodeling is knowing how to use ultrasound. If you don't know how to use ultrasound, you're very likely to cause an injury to the lung. So more importantly than knowing how to fracture or break a rib is knowing how to safely use ultrasound, so you get the maximal use out of the technology and get the safest procedure for the patient. So here I have my ultrasound. I have a rib right here in the center. It's a small little white structure, and above me is muscle. And so right here in the middle of the screen is the actual rib, and down below that is the lung that's moving. So one of the first things I do is I take my numbing medicine, my little local medicine here. I go through the skin, and I go down to the rib, and then I inject that local medicine. And you can see that medicine forming right above the rib there. So I've put in the local medication, and so I'm gonna go for 5 ribs here in the back. And you can see this tiny little incisions that would go in with a little needle, almost the size of a freckle. So this is rib number 8, 9, 10, 11, and 12. I'll go in with what's called the piezotome. Piezotome is a device that's used to cut bone. It actually irrigates the skin, and it provides some numbing medicine at the same time. And so I use this to make gentle cuts in the bone before we fracture it. Alright, so I've used my piezotome now to score the rib, or to cut the surface, and the next thing I'll do is I'll apply some pressure just to create that monocortical fracture. Dre sculpt rib lux, that's how I do it. Now I'm just checking to see the angle of the fracture, and there it is right there. That's rib number 12, 9, 8 total. So I can see the lung sliding right there in the ribs. No evidence of injury. So the rib is above, the lungs below, without any injury. I just want to point out something. I'm doing the rib remodeling, but I want to show you that I've already done the lipo and there's only a little bit of fat left. So what you're looking at here in the screen, this is the rib, and then above it is the muscle, and then here is the fat. Now I've already done lipo. So what's important is that I always talk about there's two layers of fat. One is the deep layer and one is the superficial layer. As you can see, I've left both of them pretty similar in thickness, and so I haven't left her with a whole lot of fat, but just enough to prevent contour irregularities. When you see irregularities in the skin, it's typically due to over-aggressive superficial liposuction. So I always leave a nice thin layer here at the top, right underneath the skin, and that helps to keep a nice contour where you get lipo. All right, so I've used my piezotome on the patient's left side now, so I've scored the ribs with this atraumatic piezotome. So now we're gonna create a monocortical fracture of the ribs on this side. So you can see when I really bring those ribs in with the corset, you'll see kind of how that new waist is going to take shape. So that's the power of rib remodeling right there, giving you that smaller waist. The common question I get is, will rib remodeling fix my scoliosis? And the short answer is no. Scoliosis typically is an issue with your spine and your hips. And so with rib remodeling, we're only addressing the ribs. Now I do have a technique where I can differentially fracture the ribs in certain areas, and I can change the angulation on one side versus the other, which does help to mask the appearance of the scoliosis, but no, rib remodeling does not correct scoliosis. So we're going to address the anterior ribs. I've already done the posterior rib remodeling, and so I always combine the anterior with the posterior for multiple reasons. In this case, as you can see, she has a lot of anterior rib flare, and so you may not be able to correct 100% of this without resecting this extra bone and cartilage, but we will be able to decrease the projection of it significantly. So both sides. Her left side sticks out more than her right. Very, very common. Partly because of when you're an embryo, you have the heart and lung forming on this side and just the lung on this side. And so oftentimes that pushes that cartilage and that bone out just a little bit more. So the goal today will be to decrease how much this protrudes, and that will actually give her a flatter stomach during her tummy tuck. Believe it or not, the six-pack of muscles that we all have, men and female, are attached to the ribs. So if you have anterior rib projection, that's always going to leave you with some protrusion during your tummy tuck. So you heard that, and that was basically just a monocortical fracture on the anterior surface of the rib, which is then going to help decrease that projection. So once I've completed the ribs on this side, you'll see it projecting quite a bit less compared to the other side. So I've fractured 3 ribs here anteriorly, and I've already have decreased projection of this cartilage here. So ultimately what will happen is, as the patient's wearing the corset, not only will she bring in the waist in the back where I broke ribs 8 through 12, but also here anteriorly we're also addressed ribs 7 through 9. So it's just a matter of time until this gets even flatter. And so we'll show you a side by side so that you can compare the difference. So I've addressed 3 ribs anteriorly because they were causing quite a bit of protrusion on her right side. And so essentially all I've done, this is a Q-tip here, your ribs can bend and move. All I've done is create a small fracture right here. And so that's gonna cause this projection to go down quite a bit. So that's essentially all I've done to the rib. I've done that posteriorly and anteriorly. Small monocortical fracture on the rib, just a small little break. Eventually new bone will form at this break, and that'll be the new permanent position of the rib. So I've already done the anterior rib remodeling on her right side, and I'm gonna do the left side next. You know, people are always saying, are there any big scars? There's not, so I just use like a tiny little needle point incision, just super small, to access the ribs. And so those will heal. She already has lots of freckles, it'll just blend in just fine. But notice the difference in the contour now. This used to be poking out a lot more, and now it's a lot flatter. As she wears her corset, that's gonna even go down even more as that bone continues to bend, and she'll have nearly a flat abdomen. So pretty impressive, the power of rib remodeling. There's a little circle on the screen there. That's actually part of the rib, but it's the cartilage part of the rib. So that's what makes it a false rib, is this cartilage does not attach directly to the breastbone. If I come back a little further, that's that little white line, that's the bone of the rib. So it goes bone and then cartilage, bone and then cartilage. So I've done the anterior rib remodeling on both sides, about 3 ribs on each side, and so now the next part will be the tummy tuck. So now you can certainly see, you know, those contours have certainly changed now that I've done the rib remodeling, so we have less anterior projection. The goal is to wear a corset, which is going to actually help that projection decrease even more, which will ultimately help give her a much flatter stomach during her tummy tuck. So when we're doing a tummy tuck, we have to design the incision, and each patient's going to be slightly different, but there's a couple of key principles. You never want the scar too high above the pubic area because that just looks unnatural, and when you wear certain clothes, the scar peeks out. At the same time, you want to put the scar low enough so that you get somewhat of a pubic lift. In patients that have lost a lot of weight or, you know, have carried very low pregnancies, you often get extra skin on the mons pubis area. The scar needs to be low enough to give you an actual lift. In this case, this patient's had a previous C-section. You can see her C-section scar right here. And one principle of a tummy tuck is you should always excise that C-section scar. So your incision for the tummy tuck should never be above that. So you always want to come below that. Alright, so I've already made the incision for the tummy tuck, and we're starting to elevate the flap so that we can remove some extra skin. One question is what happens to the belly button? So as long as your belly button hasn't been too scarred from multiple previous surgeries or a umbilical hernia repair, we can typically save that belly button. So I'll show you kind of how we do that. So I've got some sutures inside the belly button just to give me some grasp, and then I'm actually going to lift up here with these hooks, and then I'm actually going to cut it out like almost like a little donut. And the skin around the belly button, that will be discarded, but the belly button itself will be preserved. Okay, so I've elevated the skin flap here. This little hole here is where the belly button used to be, and so now the belly button's here. So now we're going to do the muscle repair. So she's had 4 kids, so her muscles have been stretched out. Surprisingly, her diastasis is not all that bad, but the goal is to make this abdomen as tight as possible and flat. So I'm just going to mark the midline here, and then I'm going to mark the border of the muscles, and this will tell me exactly how much I'm going to tighten. So when I start the muscle repair, I start right up here by the breastbone, and it comes all the way down to the pubic bone. So some people carry their kids low, some people carry them high, some people carry the center, but the goal is to repair all that muscle to get you as flat as possible. So I've finished a triple muscle repair application. So I always do 3 layers. And so now you can see the difference from before I did it to afterwards. So now you have a much tighter abdomen. So all that fascia on top of the muscles has been oversewn and tightened. And that should help give her a much more stable core and to help flatten her stomach that those 4 kids stretched out. Sometimes patients that don't have a lot of skin getting a tummy tuck will have a vertical incision. And so people ask, well, what does a vertical incision mean? Well, you have your horizontal incision, and that's the typical incision that we make in order to access the muscles, repair that, and remove extra skin. So when we release the belly button, there's always a little hole right here. So this is where her previous belly button was. You know, it's right here, it's attached to the muscle still underneath. If I pull this all the way down, in people with a lot of extra skin, I can usually get all the skin from the top of the belly button on down, and this hole gets removed. However, if for some reason you can't get all this extra skin out, then you have to close that in a vertical line, and that's what a vertical incision is. So the new belly button would be here, and the vertical would typically be somewhere below it. So we're going to do everything we can today to avoid that vertical. We're going to sit the patient up, we're going to release a little bit more skin and pull off as much skin as possible. So during a tummy tuck, I inject a lot of pain medication, and I feel like this helps the patients for about 3 or 4 days really get a lot of good pain relief. It's a long-acting pain medicine. It has Marcaine and some other medication in there, which really helps you to breathe a lot easier during that first 2 or 3 days post-op. We often get asked, you know, how long is recovery or what's it like after a tummy tuck? Most people will take probably about 3 to 4 weeks off of work. No heavy lifting for at least a month, and we're talking about anything over 10, 15 pounds. If you have young toddlers at home, you should not be lifting those or holding those kids on your hips, just because that's going to put pressure on your incision and it could cause you to have failure of your muscle repair. As far as walking, we want you walking the night of surgery. So it's important to get up and move around. Most people think that after a tummy tuck, they're gonna be just bed fast or just always laying in bed, and that's not what we want, because that will greatly increase your risk of blood clots. So we want you up, walking, moving, really helping that circulation. First week is pretty rough, can't lie. You know, the hardest thing is you have to kind of sleep sitting up in a chair so you don't put too much pressure on your incision. The second week, you start to get a little bit of your energy back, even though the swelling is getting worse. By the time you get your drains out, usually by the end of week 2, your energy starts to pick up a little bit, and you start to feel recuperated to some extent. You're not ready for exercise or heavy lifting just yet, but usually by the end of that 4th week, you're starting to feel more like yourself, ready to get back to work, ready to start being you again. So doing a tummy tuck today, so we made our incision, we've repaired the muscles, we've freed up the belly button. Now we're getting ready to set the patient up so that we can remove some extra skin. But the main thing I want you to appreciate is, as I'm pulling the skin down while we're still laying flat, definitely take a look at this rib cage compared to where we started. So she had anterior rib flare, and so through strategic fracture of the anterior and posterior ribs, that has been improved. And so as you can see, the before that's on the screen, you can see how much of a difference has been made already with her just laying flat. The goal will remove this extra skin, and now she's gonna have a much flatter, tighter abdomen from taking care of those anterior ribs. So whenever I do a tummy tuck, I always use something called progressive tension sutures. Some people call them quilting sutures, and the whole point is I can advance this skin down and place sutures underneath, and that helps to close the space between the skin and the muscle. The advantages of that are it takes tension off of the flap, decreases the amount of space where a seroma can actually form. So those are called progressive tension sutures, and they just start from the top, and they're in multiple places, and they just pull that skin tighter and tighter so that we get you the tightest abdomen possible. All right, so we removed the extra skin, and we've just stapled the skin shut for now until we do our final 3-layer closure. So this is just kind of shows you how much skin comes out. Even on somebody who's very small and petite, you can see how much skin comes out. And so this little hole here, this was her old belly button. And so this is just the skin and some fat underneath, but that's a lot of skin that comes out even on somebody this petite. So a lot of people ask, do I do drainless tummy tucks? And the answer is very, very rarely. The reason why is because I do a lot of Lipo. Lipo 400 involves a removal of a lot of fat, so I have to put a lot of fluid, or what we call tumescent solution, inside of you in order to decrease bleeding and for pain control. Well, not all of that fluid comes back out when doing Lipo, so we use a drain in that case. This is just a little silicone tube that goes in this right under the skin, and that helps to collect all this extra fluid. As you can see, like a lot of this extra fluid coming out now, that's just all fluid from the Lipo. It's not blood, but it's just mainly the tumescent fluid. And so when people often talk about doing drainless, they are leaving incisions open in the back. And so even though there may be no drain in the front, you're leaking fluid kind of all over your garment in the back. And so I prefer to use a drain because I want control over that fluid, and it helps your bloating and your swelling resolve a lot faster. So all of the tummy tucks that I do involve a 3-layer muscle repair or plication, but also when I do closure of the skin, I do 3 layers. I do a deep layer, an intermediate layer, and a superficial layer. So it's very important. As you can see here, I've already started closing the top and 3rd layer, and you want those skin edges as close together as possible to get the best scar as possible. Now, a lot of scars are based upon your genetic. Darker patients often get darker scars. It also depends on how much collagen you make. A term you may hear often is a keloid, and it's very rare to get a keloid unless you genetically have it, such as you had your ears pierced and you got large lumps of scar tissue that form. So the biggest reason for revision for probably a tummy tucks is for the scar, depending on how it heals. So that's why it's very important to stay kind of seated in an upright position so you're not putting too much tension on that 3-layer closure post-op. All right, so part of the tummy tuck is to redo the belly button. In this case today, we've actually saved the belly button. So what I've done is I've made a tiny hole in the skin where I want the new belly button to be. Her previous belly button was sitting a little low, so I'm gonna bring it up and put it a little bit higher. So I've made a new hole, so I'm just gonna clean out some of this fat here. If I reach down, now I have the old belly button right here, and I'll be able to pull that through the skin and reattach it. key with the belly button is that you want it to look natural. I think some people just kind of make a hole and pull the belly button up and it doesn't look natural. So we try to make it look as natural as possible, and there's multiple steps to that. If you ask 100 plastic surgeons how they do their belly button, you'll get 100 different answers, and that's okay. But you want to make sure you find a surgeon whose belly buttons align with what you're looking for in a tummy tuck. Just finished an amazing mommy makeover. So this patient has had 4 kids, so she had some muscle damage, some separation of the muscles there, but she also had a very boxy waist. So she came and I did my signature Lipo 400, a Dre Sculpt BBL with fat to the buttocks and the hips. But unique to this case is I did posterior and anterior rib remodeling. She had a very, very boxy frame, so I broke 5 ribs on each side and the back in order to narrow that waist, and I did a few ribs on the front. As you see here, her anterior rib flare, which was one of the main concerns she had, has now been essentially fixed, and it's going to go down even more as she wears the corset. So as you can see in the pre-op photo here, she had a lot of anterior rib flare, and just with some manipulation of these anterior ribs, that's been improved. In addition, so we did this tummy tuck. She has a nice low incision that will be hidden very well in a bikini or underwears. Nice new innie belly button, super flat abdomen. She's going to look amazing.